Okay, I think we're live. Hi, everyone. Thank you all so much for joining us tonight. It looks like we have a great turnout, so thank you to the Harris team for all your planning and hard work in setting this up. My name is Amy Spellman. I am the Associate Director of the University of Chicago Health Lab at the Harris School of Public Policy, and I'm honored to be here tonight to MC, if you will. This is the second event in the Summer of Social Impact series, and we have a wonderful panel lined up, and I'm really looking forward to the conversation. So this evening's event will focus on the challenges and innovations in emergency response for Chicagoans. Cities across America are seeking safer and more effective ways to assist people experiencing addiction and mental health crises, particularly in this post-COVID world. Chicago is now piloting several alternative first response models with the goal of improving prevention and follow-up and reducing the risks of violence or arrest in such encounters. So I'm really excited to kick off the discussion with a fireside chat between Health Lab co-faculty director Harold Pollack and Dean Baker. Afterwards, we'll hear from a panel moderated by Health Lab's Jason Lerner. The panel will feature Dr. Nika Tapia, the Managing Director of Justice Initiatives at Chicago Beyond, Joel Johnson, CEO and President of TASK, Dr. Nicole Gestala, a practicing physician at the Department of Family Medicine at UI Health, and Matt Richards, the Deputy Commissioner of Behavioral Health at the Chicago Department of Public Health. So without further ado, I will hand it over to the Dean.
Thank you so much. I'm so thrilled to be here with you all, and especially to be able to talk with Professor Harold Pollack about some of the amazing work being done at the Health Lab. And before I dig into those really important questions about first response and how our system is or isn't functioning for the citizens of Chicago, I want to ask you about the general approach that the lab takes in terms of furthering research versus implementation on the ground, and how the partnership with agencies and stakeholders around the city works in practice.
So we're trying to improve the health of people in Chicago and the country who really face diverse and complicated challenges, where we want to improve the healthcare system and the health services that people get, but also address the social determinants of health, and to see how can we create a more integrated way to support people and to meet their needs that may include social services, may include housing, or may include addiction treatment, may include other things that respond to people's needs. And so, we have a $4 trillion health system, but it's one that is very fragmented. And faculty director Meltzer does a lot of really important work in the hospital with patients, for example, in an intervention called the Comprehensive Care Community and Culture Program, that says, hey, we have these older patients, they have medical needs, but they have so many other needs too. And also sometimes the need is people are lonely and they need social supports, things like that. So we do a variety of things, working with agency partners, working with communities, trying to bring a sensibility in our work to understand what do our agency partners feel would be valuable to help people, what people feel would help them, and how can we assist with that. So that's sort of our general philosophy from 50,000 feet.
So how do the social determinants of health, or the outside inputs, affect people's health outcomes versus healthcare that they get once they show up in the doctor's office or the hospital?
Well, first of all, most of what we do that affects our health does not involve healthcare. I can say that having had a wonderful donut earlier today, which is really not on the recommended list of foods that my doctor might tell me to eat, but also in very mundane ways and very profound ways. Imagine that you are at risk of COVID, and you see a public provider or your doctor says, you really should stay physically distanced from other people to protect yourself and to protect your community. But you're a minimum wage worker, and you're living in a multi-generational house, in the Pilsen area of Chicago. How are you actually going to do that? You need help to do the thing that we all want to see you do from a public health perspective. So we have to say, how do I make it livable for you? Maybe I get you access to Instacart while you're staying physically distanced, or we work with you to figure out how can we create a housing situation that is physically safe, And if we want the epidemiological realities of COVID to change, sometimes that means changing the economic realities of people's lives, who are the people that really are at the core of either becoming infected or perhaps infecting other people. That would be just one example. I think, as you know from your own work, formal health services are just a very small of what we need in order to stay healthy.
So what the lab is dedicated to, and what we throughout Harris are dedicated to, is applying a rigorous analytical lens and an evidence-based approach to figure out what actually works and what doesn't work. I'd love to hear some examples from your own work or from other work at the lab of things that work surprisingly well, or maybe things that surprisingly, unfortunately, didn't work.
So a lot of our work concerns interventions that are trying to help people at a particular point of vulnerability in their life. For example, with our task partners, we worked on something called the Supportive Release Center right outside the Cook County Jail, trying to help people right when they leave the jail to make sure that people don't end up homeless, or maybe they don't reinitiate drug use that night. And we have a number of trials. There's a big randomized trial that we're doing called Reducing Opioid Mortality in Illinois, in jails and prisons across Illinois, trying to help people who are leaving. And we've had both success failures in those efforts. One of the more humbling things that we've learned is, boy, you really have to understand what is an effective sales pitch that is attractive to people who are leaving that environment, so that they actually want to come to your intervention. If we say to people, there's a place you can come if you have no place to stay tonight, a lot of the younger men leaving the jail, they would just say, that's not me. I got plenty of places to go. I got all kinds of people that would love to have me tonight. And the sense of self-stigma, they just won't come. They'll see actually the older borderline homeless guys who come to the intervention, look at those men and they will say, that is not me. And they will not come. And so we found from some of our younger men, we had a disappointing outcome in some of our interventions because we hadn't really thought about how to make an attractive to them. But at the same interventions, we see some real successes. We see, for example, when the older men we really did see, when they came to the SRC, there were real improvements in tangible outcomes for those people. We've had, so that's certainly one success that we've had. We've also had a number of success where we've used big data methods in first response to try to understand who is at real risk of having, say, a violent encounter with first responders. And I'm sure that will come up later, but we have found that some of the methods that people learn at the Harris School around machine learning and predictive analytics, when you combine those with administrative data and also by talking to stakeholders to get a sense of their tactile understanding, that you can really identify people who need help and then reach out to them with effective services. So that's been really gratifying for me.
So it sounds like what you're saying is that you need to reach the right population with the right message, the right framing of the message at the right moment, which sounds really hard to do. It sounds like you need real precision policy intervention, and the data that we are getting more access to and the data science tools that we're using might help tailor those interventions so that you're reaching people at that exact moment when they're going to hear the message that they need to hear to get the help that they need to get.
I think that's right. And talking to people with lived experience and talking to people on the front lines so that they can educate us. Because so the data allows us to generate some insights, but then we go and we talk to people and we realize, oh, that data didn't quite mean what we thought it meant. And we talked to the manager of the homeless shelter, who was actually the person who would enter the data, or the EMT, or the police officer, or the firefighter, or the consumer of 911 services. So the combination of the technical skill that we have with the tactile understanding and policy understanding of our partners, that's when we're really operating on all cylinders, when we can bring those things together and say, okay, here's a moment when we really can help someone. And that's what we, that's really what we live for. And I think these successes are really important. I think throughout all of the urban labs, a lot of the successes that we have, one of the things that I like to say is it gives people a sense of realistic, evidence-based optimism, that we can do things that actually help people. One of the challenges we have in a place like Chicago is the structural problems are so profound, the challenges are so profound, whether it's the opioid epidemic or violence or the gun problem, whatever it is, you can become very pessimistic and therefore very passive about trying to deal with these problems. And when you show wins, even if they're not super dramatic wins, but they're real wins that help people, it gives people a sense of optimism and of efficacy. And I think it's a really valuable thing that Urban Labs has been able to do, with our interventions, since in the decade at least that I've been involved in.
Well, two really important things that came from your answer there. First, it seems like the partnership with stakeholders and implementers on the ground is crucial, that academics sitting in our offices have no idea what's really going on and what the data mean, what the lived experiences are, and also where we might be able to help design policies that are going to do the most good. The partnership is enormously beneficial for helping to deploy the full array of talent and toolkits that different people bring to the table. And the second thing, I do feel as though in healthcare, my own area is studying the US healthcare system, and I feel like incremental improvements are underappreciated, where people are looking for something that will fix it. Yeah. There's no one thing that's going to fix it, at least nothing that we can actually do in a reasonable time frame in the world that we're in. And every 1% better, 1% better, 1% better matters a lot. And I feel like sometimes those incremental improvements get undervalued when they're wonderful for the people they're helping and they add up. And that's how you get to bigger improvements.
Sometimes say, how can you solve the opioid? And that's the wrong question. We things that help.
So I want to turn to the topic of first response and the work that you're doing through the 911 system. And I think it would be helpful to just set the stage by starting with some insights from you about what the system is supposed to be accomplishing and how it actually functions today.
Well, I think that's a great framing. You may have to mute, by the way, when I'm speaking, getting some reverb. Does that sound better? So the 911 system is a tremendous resource in that, if you're having an emergency, the idea that there's this place that you can call 24/7, 365 and get help is extremely valuable. And there's no question, if you're having a heart attack, if someone breaks your home, 911 is so valuable. It is also so limited. And I think understanding the necessity and the limitations of really getting a great first response system is really, really important. It is one of the real challenges in 911. So one of the things that we find is people are coming to us and they're saying, I personally do a lot of research that involves people with behavioral health problems. They could be from serious mental illness, could be from intellectual disabilities, could be from addiction, or who might be behaviorally dysregulated. And there's a tremendous effort to make sure that when a 911 call is made that involves someone in a mental health crisis or something related, that the first responders know how to manage that incident properly without violence in a de-escalating way. I was on the Police Accountability Task Force in Chicago after Laquan McDonald was killed. And we worked on efforts to improve training of police officers and firefighters and others, which I think is just incredibly valuable. And there's some crisis intervention teams or crisis intervention training that is just really valuable for officers to understand how to interact with people in mental health crisis. And when we talk to people, mental health providers around Chicago, they really tell us, the CIT trained officers, they're so valuable. We specifically request them when there's an issue in our homeless shelter, wherever, and we feel so much more confident about calling, knowing that a CIT officer is going to come. And that's all I think is absolutely fantastic. While though, that is just one piece of the puzzle. If a 911 call ends in violence, there may be a cell phone video that shows the tragedy. We've all seen on television those things. If a man who is homeless is trying to get help and his request for housing is lost in bureaucratic red tape, is under a coffee cup and no one ever deals with it. There's no cell phone video of that. There's no cell phone video a person who's trying to get mental health services is poorly served, or there's no cell phone video when there is a 911 call, and then for the next month there's never any follow-up to deal with whatever the problem was that led to that. And so a lot of our work is really around how do we prevent that 911 call? How do we build on that 911 call so someone follows up? Say in your home, you have a son with a mental health challenge and you have to call 911 because he hits you. Did someone come and make sure everybody else in the house was okay, to talk about what do we do to prevent this from happening, or to see maybe he should be in a different residential setting? Those are the kinds of things that I'm really very focused on in my work. That was a very rambling answer, but those are the kinds of things that come from that.
So what are some strategies for making that happen? What's the intervention, and how do you test to see if it worked?
So one of the things that we've done is we've used predictive analytics to identify people, places, and events where there's a real risk of a problem. And then we try to act proactively. So if someone shows up as being high risk of a violent encounter with the first responder, you can go out, you can talk to them right now when there's no 911 call and say, hey, can we meet your needs? Can we connect you with a social service provider now so that we can help you? How can we make sure you have the housing you need? How can we make sure that the people in your family have the issues that you have? The other things we can do is educate the public and help the public provide information to first responders. And something that's very basic. For example, there's something called Smart 911 that families can register for that can have things in there like, we speak Vietnamese. That's actually incredibly important, so that the first responders actually understand. You got a sense who speaks Vietnamese if you want to interact with family. The 911 call operator is not going to recognize that it's Vietnamese in the 30-second call from a frightened person. Or things like, my son has autism, so don't blare the siren when you drive up, because that's just going to make him even more agitated. Or my wife's psychiatric medication and her insulin are up in the second floor bathroom cabinet. So if you come up and she needs her medicine, that's where it's going to be. Some very, very basic, mundane realities that we can improve. One of the striking things about first response is so often, whether it goes well or poorly, depends on just very mundane aspects. If it's Tuesday at 2:00 in the afternoon in Uptown in Chicago, and they're standing in the street and he's cursing at Jesus and Jesus is cursing back at him, the first responder is going to be really pretty good in that situation, because it's pretty obvious what's happening, and they have the time to spend 45 minutes with that guy if they need to. And so some of the work that we do on first response is, well, what do you do if it's at 9:00 at night in Inglewood and there's just a lot of service calls coming in? How do we understand how to manage these situations when the system is more stressed? And those are the kinds of things your partners can teach you that you're not going to know as an academic sitting in your office.
So I want to unpack several of the things you raised there. First, you talked about using predictive analytics to know ahead of time, before the 911 call happens. How well do those predictions work? I could imagine a world in which it's just very hard to predict because it's idiosyncratic and the data don't tell us that, or a world where you can know pretty well ahead, and if you have the resources, you can forestall a lot of the 911 calls. Which world are we in? It
depends on what the question is, what kinds of interventions we're talking about. If I wanted to find the people at extreme risk in Chicago of having a violent 911 call, it turns out that those people are somewhat easy to find, like the 50 people in Chicago that are the really heavy users. Because the guy who's had 45 calls last year that some of which ended up in violence, it's pretty likely he's going to have 46. And so what we find for those people, you can basically just look at the sort of frequent users and identify a lot of those people. That's not so for prevention. If you say, I want to have a program that's going to identify, say, the top 5,000 people that face some risk, what we find is that the predictive analytic tools work much better than sort of looking friendly faces, frequent flyer type people. And also, of course, we can use those for prevention. Sort of by definition, you're not in prevention if you're dealing with the people that have already had a lot of calls. So we use what are called random forest methods with machine learning and to identify people, and we get about what's called twice the positive predictive value compared to some of the sort of how many times have they used it before type methods, frequent flyer methods. And we all find that some of the variables that jump out of the machine learning give clinicians some valuable insights. And if the EMTs write down in their case notes when they went to a 911 call, nothing bad happened on this call, but the guy was aggressive. That's prognostic. And when we find there are characteristics of people, places, and events that lead us both to identify the people and also to identify some of the characteristics of situations that we might improve. Very often, if say there's a group home for people with developmental disabilities, you see, wow, there's a 911 call that could have been violent, and then you go there and you say, well, what was the staff doing in the half hour before that call was made? And you find out, well, the staff was telling guys he got more and more agitated. If you don't calm down, we're going to call the cops. Well, let's sit down and talk to the staff members about what's the approach of 911 and what's likely to de-escalate that situation. So the predictive analytics can sometimes point us to things, especially when we bring that to our partners, can point us to some real insights about what led up to a situation that might allow a better intervention.
And then how are you working to assess whether these interventions actually achieve the goals that you're aiming for? How do you know if it worked or not?
Oh, that's a great question. So one thing that we're firm believers in randomized trials. And so one of the things that we have been working on, and our partners at the Chicago Department of Public Health and elsewhere work with us in the design of some of these trials, can we identify a large group of people that we believe are at some risk of an adverse event, and then do a randomized trial that says, hey, only so many outreach workers to go and do a intervention for people at risk. Let's assign them with a lottery, and let's see whether the folks do better with that. And how do we, and of course the design of the trial so they're ethically appropriate, so that they are, so that stakeholders see their value and believe that they're done in accordance with community values is, of course, a tremendous part of the exercise. For example, one of the things that we do is we do predictive analytics, and then with all the possible variables we can use, and then we go back and we say, well, race popped into that predictive analytics model. Let's take that out. Let's take out people's arrest records. Let's take out some things that the community will say, hey, we don't think that you should be allocating services based on that variable for legal reasons, ethical reasons, or because we think people in our community are arrested more often than is fair. And we say, how would that change who we would send our services to? So we can also evaluate the success of our interventions sometimes in terms of, are we using in the community says, hey, we're happy you're using that information. Can we take out information that the community want us to be using and still perform well in terms of our statistical yardsticks that we usually use? So there's no single way that we determine the success of our interventions, but those are some of the things that we do.
That's a great tour of some of the many tools that the lab deploys. And this is such important and fascinating work. We could talk for a long time about it, but I know we have a packed agenda. So I'll just ask one last question, which is, I know that you're interested in working beyond Chicago, around the country, and you have many partners for this work. You mentioned scarce resources and how differently things go on a busy night in a busy neighborhood for responders who have no time, no resources, and how that plays out very differently in different communities. What are you thinking about and learning as you deploy these kinds of interventions in different parts of the country? And what do you see as like the critical resources that we need to be deploying to avoid some of the bad outcomes and to promote much better outcomes?
I'll mention two things in closing. So one thing is Rebecca Neustadt, our executive director, is running a project called Transform 911, where she's really leading an effort where we're working with 911 folks around the country and saying, how can we improve first response and learn from places, rural places, urban places, learning best practice from around the country. And some of the issues are, how do we make the job of 911 call takers more professionalized and a higher job quality that's more doable? You have these women who are sitting, taking calls from terrified people, having a 30-second phone call, trying to figure out, how do I help you in this emergency? How do we support those call takers? How do we use predictive analytics, not only in a big city like Chicago, but maybe in a smaller place that doesn't have a huge stable of data scientists available? I should mention that COVID has been a real window into this. First of all, people have been real innovative around the country, and we've also seen it's been a mirror to some of the real failures of the first response system that were always there but were easily overlooked. So one of the things my colleague Will Parker, Caroline Kelly, and I have done some writing about disparities in mortality rates among ICU patients that are taken by ambulance essentially to the wrong hospital. You're in the far side of Chicago. What really needs to happen is you need to be taken to the University of Chicago Medical Center ICU, but you're taken to another hospital that doesn't have the same level of staffing and machinery as the University of Chicago does. And it turns out that, and there are much higher mortality rates in the Genetic community hospitals in that setting. And it's not because of any high-tech issue that people at the U of C are sort of at the forefront of some scientific understanding of COVID. It's that they have more people who can position people's bodies properly in the ICU. They have the right machines, and they can do acute respiratory care with more effectively. And way before COVID, people were always quietly dying because we did not have a regionalized system for acute respiratory care. And COVID has been a mirror to that in our first response. And we see that with a lot of issues. And one of the things that actually makes me optimistic as we learn from the year and a half that we've all just been through is we have really learned both how to be more innovative, but also it has brought to the surface some of the failures in our systems that just COVID made so obvious that we had to address. And so that's true in first response and in other ways as well. And so I'm hoping that we can do more to learn from COVID and to bring that practice here in Chicago and around the country as well.
Thank you so much for sharing some of this, really crucial work with our whole community. And I'm going to look forward to hearing how all of these interventions and evaluations go in the coming years and months and years. And let me turn the microphone back over to our MC.
Thank you, Dean Baker.
Thank you so much, Dean Baker and Dr. Pollack, for that really interesting discussion about the role of research and particularly predictive analytics and how it can be leveraged and used in some of these really critical experiences. So changing gears, I'm so excited to introduce you to this fantastic panel. I have had the privilege of working with some of these individuals one-on-one, more broadly with their organizations. Not only are they all leading experts in this field, but they are all so committed to making Chicago, particularly communities in Chicago that have been systemically underinvested in, not just safe, but also thrive. So bear with me. We have many panelists to introduce. I will try to keep this short. I could probably spend 30 minutes introducing them because they just have such rich backgrounds, but I'll try to be brief. So first, we have Dr. Nika Jones-Tapia. She is the Managing Director of Justice Initiatives at Chicago Beyond. Her primary focus in this role is on young people experiencing trauma, including those whose parents have been incarcerated. Since joining Chicago Beyond, she's collaborated to launch Beyond Incarceration, a pilot program in partnership with Cook County Sheriff's Office and the Chicago Children's Museum, focused on reducing the stigma and trauma that surrounds young people impacted by parental incarceration. Prior to joining Chicago Beyond, she served as a senior fellow at the University of Chicago Institute of Politics. And before that, she served as the warden of the Cook County Department of Corrections, spearheading several strategies and programs to promote wellness and reduce recidivism. So welcome, Dr. Jones-Tapia. So next up, we have Dr. Nicole Gestala. She is a practicing physician at the Department of Family Medicine at UI Health. She focuses on preventative healthcare and chronic disease management for pediatric, adolescent, adult, and OBGYN patients. She has an interest in addiction medicine, including medication-assisted treatment for opioid use disorder. She graduated from Loyola University Stritch School of Medicine and completed her residency at the University of Iowa. So welcome, Dr. Gestala. Next, we have Joel Johnson. He is the president and CEO of TASK and leads their efforts to address the everyday realities and structural barriers that impede people's opportunities to thrive. Joel has spent his career advocating for individuals and communities that are dealing with trauma, substance use disorder, mental health challenges, family disconnection, and social, racial, and economic injustice. Prior to becoming TASK's top executive this past March, he served as executive vice president of Friend Health, an FQHC here in Chicago, and concurrently as the president of Human Resources Development Institute, HRDI. He has worked at places like SOS Children's Village, Illinois, the Child Welfare League of America, Chicago Commons, among others. He was recently appointed to the City of Chicago Board of Health to advise the mayor on public health matters, and also serves on the Cook County Equity Fund Task Force, which advises the county board president on strategic investments to address historical disparities and disinvestments in Black and Latinx communities. So welcome, Joel. Next, we have Matt Richards. He is a healthcare administrator and licensed clinical social worker and currently serves as the Deputy Commissioner of Behavioral Health at the Chicago Department of Public Health. In this role, he oversees CDPH's violence prevention, mental health, and substance misuse and recovery programs. He is also a lecturer at the University of Chicago in social work and public health. And prior to this role, he served as executive director at Care to Prevent at the University of Chicago's Pediatric, Adolescent, and Young Adult HIV program. And then last, but certainly not least, our moderator this evening is Jason Lerner. He is a portfolio director at the Health Lab, and he oversees our crisis response and diversion and deflection portfolio. He is a trained attorney and social worker and has dedicated his career to the pursuit of fairness and equity in our nation's criminal justice system. His research interests include public health law, administrative law, and criminal law, in addition to drug policy and local government policy. Prior to joining Health Lab, he spent several years at Crime Lab New York, which is one of our sister labs, where he managed multiple large-scale field studies. So welcome, Jason.
Hi, everyone. I'm so excited to be here tonight to talk about crisis response. Before we start, I wanted to express my thanks to Dean Baker and Dr. Pollack for a wide-ranging discussion that highlighted many of the issues that we'll be discussing during this panel. And also thanks to Amy for helping tee up the conversation and those great introductions of today's panelists. And finally, a big preemptive thank you to all of the panelists. I know you're all so busy doing the great work that you do, so thank you for spending your time with us tonight. So we're here to discuss crisis response, or what's sometimes referred to as emergency or first response. It's a topic that's been on lots of people's minds over the past year, especially as it relates to folks dealing with substance use or mental health challenges. As moderator tonight, I view my job as mostly to stay out of the way and let our incredible panelists discuss the issues. But one thing I wanted to say to lead us off is that there have been long-standing challenges to crisis response in Chicago, just as there have been all over the country. While today's panel will situate the discussion in Chicago, the challenges and some of the promising solutions discussed have broad applicability well beyond Chicago. And so to help us get started, I'd like to ask Matt Richards to help us frame the issue.
Thanks, Jason, and it's a pleasure to be with everybody. I mean, I think there's really a wide-ranging conversation across our country that the ways in which we've been talking about emergency response through 911 systems is limiting. And, you know, when we're thinking about crisis response, we're normally talking about an emergent event in which public safety professionals, paramedics, or firefighters are dispatched alone or in combination in order to respond to an emergent event. I think there's a growing recognition, though, that folks experience emergent events for a variety of different reasons, often that are related to unmet healthcare and social needs, and that those combinations of professionals don't always have the best training or the skills and resources that are needed to resolve the crisis in question, but also to provide the appropriate follow-up care in the long term, to interrupt cycling and to make sure that people's needs get met in the community. And I think you're hearing a lot of that related to mental health crisis response, substance use crisis response. I would add homelessness. I would add other types of crises that arise from unmet social needs. And so one of the things on the city side, we're really looking at, it's a priority of the mayor, it's a priority of the health department, is really to think about how we layer in new groups of professionals into the 911 response system. How do we embed professionals into the 911 call center where we can try to resolve more calls over the phone without dispatch? How do we develop new ways of following up with people who have contacted 911 to make sure that their fundamental needs were met by the resources we dispatched? And how do we think upstream? What leads to crisis in the first place? How do we see the connections with systemic reinvestment or investment in communities that promote health and well-being where people live, such that they never have an acute need that requires them to call 911 in the first place?
Thanks, Matt. There's a lot to unpack here. I think a critical point that you raised is that we need to expand to really challenge our definition of a crisis, or at least the way in which we think about addressing them, both from an individual in crisis perspective, as well as at the community level. This also makes sense from Health Lab's perspective. One point that's continually stressed during our 911 stakeholder interviews that we're conducting with stakeholders all across Chicago is that when 911 is called, that may be indicative that a particular issue has become acute. But folks struggling with homelessness or dealing with problem substance use or severe mental health concerns really need consistent support to prevent the crisis from occurring in the first place. And related to this, your definition also implicates the problem of the revolving door, because the 911 system is not currently set up to resolve the issues. So another important question is, who is following up with folks in the aftermath of a 911 call to prevent that next 911 call from occurring? And at this point, I'd like to ask Dr. Jones-Tapia to help flesh out the idea of unmet needs and the ways in which we might think about expanding our definition of crisis response in order to start meeting those needs.
Sure, thank you. In terms of unmet needs, I think for far too long, we have had the flow of money and power and resources out of Black and Brown communities, and very little has been returned. And Black and Brown people living on the South and West sides of Chicago share the same biology as white people living, let's say, in Lincoln Park or the Gold Coast. Yet as we sit here today, Black and Brown people in Chicago do not have equal access to quality education or physical and mental health care or safe housing and transportation. Those investments that Matt just spoke about, the needs have never been met. And so now we're talking this evening about a crisis response. And the reality, at least from my perspective, is that we're talking about this crisis response really because Chicago, the county of Cook, the state of Illinois, and this country as a whole has not committed to the significant and sustained investment in prevention and early intervention that's required to fully support the health and wellness, specifically of Black and Brown people, but in general of poor people. And we at Chicago Beyond have been looking at this more closely. And there is a model or a chart that people often use, especially in the mental health field, called the sequential intercept model, to really demonstrate how people with mental illness and substance misuse disorders move throughout the criminal legal system. And it's used as a way to identify resources for diversion and support, as well as gaps. And if I can just describe the model a little bit for people who aren't familiar. So there's 6 different points in this model where people and systems can intercept a person's path in the system. The first point in this model that's widely used across the country starts when a person has already reached crisis, just what we're talking about this evening. So at Chicago Beyond, we have been hyper-focused on transforming this model in a way to demonstrate the value of prevention and early intervention as the first points of contact with people. And in those prevention and early intervention efforts, being sure to center community. That is important because the expertise is in community.
Thank you, Nika. Next, I'd like to ask Joel to share his perspective on delivering more comprehensive supports in the community. And then we'll have Dr. Gestala, if you could jump in with your perspective, first as a medical doctor and second from the perspective of your work at SUPER, that's the Substance Use Prevention and Recovery Division at the Illinois Department of Human Services. But first, Joel, what's your perspective on this?
Yeah, absolutely. Thank you. And thank you for inviting me to speak today. I think building on Dr. Tapia's comments, early intervention and prevention are definitely key. And the reality is we're talking about a crisis system that really, it's not really a system. We're in crisis, right? And we're responding. It's a crisis response episode, not really a system of care. And so the absence of order and a process creates more crisis. And so we as providers, in partnership with academia, in partnership with health systems and government, are trying to respond and throw out ideas and interventions. And what we run into is a lack of infrastructure, funding, bureaucracies. So it's not just crisis response, it is mental health crisis response or housing crisis response or substance use crisis response. And so my funding will allow me to do some things, but will not allow me to do some other things that I know need to be done. Or I can do it, but I don't necessarily get paid for the time, and I still have a workforce, and I still have, direct and indirect costs to cover to get it done. And I have deliverables to that funder that I need to document and say, this is what we did. And so I think sometimes, we build things with the best intentions, and sometimes we handcuff ourselves. But I think that we're moving in the right direction, more dialogue like this. We start punching holes in some of these barriers and pointing out to the funders that here's where we got stuck and here's an opportunity for us to improve this. We're starting to build that system that we're talking about, but we're not there yet. It's still crisis response. 911 is a response mechanism. But how do we get to the point where we are preemptive? How do we have a system of care that we know that, if task engages somebody at the SRC, we can hand them off to this provider or that provider to ensure that they get what they need and don't end up in our deep end portion of our system, which is jail and the emergency room, et cetera.
Yeah, thanks, Joel. I think that's a really great point about the handoff system, because I think that's one of the biggest problems. If you have two patients who enter the ER, right, one who survives a heart attack and one who survives an opioid overdose, the patient who survives an opioid overdose has a higher mortality within that year than the patient who survived a heart attack. But guess who gets all of the services, right? Guess who gets an immediate appointment with cardiology, gets started on medication. Maybe they're watched overnight and observed and then connected to sort of all of the outpatient resources, that they need. That doesn't really happen with patients who survive an opioid use disorder, right? So there's fragmentation within our medical system. There's fragmentation and then in starting them, right? Using that as an opportunity to treat a patient with opioid use disorder with medications that can really impact their life, and then directly connecting them to recovery support services or other services that they need to help them with their addiction, like we would with a patient who survives a heart attack. And I think that exact point is one of the great fractures within our health system that we really have to focus on addressing, that continuum of care, making sure that patients have that warm handoff from provider to provider, helping them go over those obstacles that the health system really, it's a lot of barriers, right? There's so many barriers in this realm that patients really need to help overcoming. And particularly those who are underserved, right? They also have challenges with housing, with food insecurity, and all of those things really just exponentiate the impact that substance use disorders can have on them. And there's really a lack of training, for medical providers to do as good of a job as we should do. And I think that's an important area that we really need to focus on as well, is having the appropriate individuals in the EDs, in urgent care sites, out in the community, who can help address those substance use needs for patients, those crisis needs. And it's generally not, doctors, right? So we really need to have the right professionals. It's not the police. It's not, EMTs necessarily. It's really our behavioral health experts and our recovery experts and peers, right? Those with lived experience have an incredible I think, impact on patients and helping them through this system.
Thank you, Joel and Dr. Gestala. What we're talking about are a number of really systemic issues, including issues of equity in the healthcare, justice, and many other systems. Bias in systems, perhaps based on the problems that people are facing, issues of funding, the way that our safety nets are structured fundamentally, training, access to care, silos. It seems like there's lots of silos or gaps in the system. It was just by design. On the funding piece, maybe there's some hope with the recent passage, for instance, of the American Rescue Plan, which will provide states with additional Medicaid funding for home and community-based care, though that funding stream is not currently a permanent one. But clearly, a more comprehensive approach is needed to address these issues. So next, I'd like to turn the conversation towards solutions and how we may rethink our approach. And so I'd like to ask the panelists, what's needed in this space? It seems like at this point in time, we have an open policy window, but you can never predict how long it will remain open. So what ideas are out there that give you hope? What's currently being tried? What still needs to be done? To kick us off, Matt, let's come back to you.
I do think it's a moment of possibility, and I think we need to take advantage of it, because you don't know how long those moments last. So, I'll give you some examples of things in Chicago. I'm really excited that we're incorporating healthcare professionals into our 911 response system for the first time. So that'll be starting in a month or so, that we have a whole new group of mental health professionals that specialize in crisis that'll be responding to 911 calls. I'm excited that when a person with a substance use disorder is arrested in possession of a substance, that by the end of the year, they will be eligible for diversion into treatment services. As Dr. Gestala mentioned, people with substance use disorders should not be criminalized. It is a health condition that's interconnected with trauma, toxic stress, disinvestment in communities. It's unethical and immoral, in my opinion, to criminalize people suffering in that manner. I think when I think about the stabilization housing, Joel mentioned this. We work with patients all the time, right, that have, let's say, a substance use disorder, and they're experiencing homelessness, and they are experiencing complex trauma, or they have food insecurity. Sometimes we don't have the right batch of resources. And so the fact that we're starting to talk about things like stabilization housing as something that should be a part of your 911 response portfolio, that you should be able to prioritize folks that are cycling through 911 and their homelessness is part of that picture for them, to get them connected rapidly to housing. So those are some examples.
Thank you so much, Matt, for sharing some of the details and nuance on what's happening in Chicago to sort of reimagine crisis response. If there's one word I would choose to describe Chicago's approach, I think it would be comprehensive. There are things happening on a scale in Chicago that I don't think is being done in many other places in terms of the different sorts of approaches that you're testing at the same time. And so now I'd like to bring some of the other panelists in to talk about their perspective on solutions. So let's start with Dr. Jones-Tapia, and then we'll have Dr. Gestala and Joel jump in. Can you tell us some of the ways that you and or your organizations have worked to address the needs of people in crisis or are on a path towards crisis?
Sure, I'll give two such example. So in March of this year, Chicago Public Schools, led by the Office of Social Emotional Learning in partnership with Chicago Beyond, launched the Healing Center framework. And what the framework is basically a roadmap for CPS to proactively and responsively meet the wellness needs of every student, as well as their support system. And this includes CPS staff, as well as parents, caretakers, and families. And so if you want to know more information about that framework, please visit chicagobeyond.org, or you can visit it at cps.edu. But it includes training, it includes a coordinated wellness response, and it includes community partnerships to help support a collective wellness in our communities. And Jason, you talked about, Chicago really kind of setting the bar for what's happening across the country. This framework is putting CPS in a position to be the largest school district in the country to take such a comprehensive approach to healing. So we're really proud of that. I'll also share that Chicago Beyond recently launched the Holistic Healing Fund. And this is a $10 million investment in systemic change that's led by Black and Brown communities for Black and Brown communities. And it really recognizes and honors the many pathways to healing, as well as the abundance of individuals who have been doing this work in community. So really proud of both of those initiatives that launched this year.
Thank you. That's really great. So we're working on several things on the state level. I think one of the areas that has been highlighted in this group is access to recovery homes, right? So that housing and substance use disorder and mental health, they all sort of go together. And then once you have, housing crisis, it's really hard to focus on engaging in treatment, right? If you don't have a safe place to sleep at night. And the supportive environment that you can, do that. So that's one of the areas that the state will be expanding is access to recovery homes, which I think will be, pretty impactful. And then the Pritzker administration today did release the report that we have invested quite a bit of money in Naloxone and direct ordering. So now community organizations, hospitals, clinics can directly order Narcan, which is a life-saving medication that can be helped to use to reverse an opioid overdose. And so these are just some of the solutions that we can sort of assist with, and then partnering, right? Partnering with CDPH, partnering to develop crisis, programs that address both mental health and addiction, and the social determinants of health, as well as DMH, and working on the state crisis line.
And then, I'll add, and Matt alluded to a pilot that was ongoing, that has now broadened in Chicago with Narcotics Diversion, where our colleagues at Thresholds are currently working with Chicago Police Department and helping to divert people away from the system by getting them into care and treatment immediately. At Task, we are working, and we're a statewide organization. We're present in all 102 counties in Illinois. We've launched a pilot with the Illinois State Police to deflect people away from the criminal justice system. And we started in southern and central Illinois, and then we'll be moving across the state at the end of this pilot in about 4 months now. But this deflection model, we have a saying, no entry. And what we want to do is make sure that we get people, substance use disorder, mental health are chronic illnesses. And as Dr. Gestala alluded to, we don't treat people with heart disease the way we treat people with substance use disorders. And so our goal is to deflect people away from, again, the deep end parts of their system, the emergency departments, the jails, and get them into treatment services, intervention services that will help them get realize their full potential and get the help that they need before they become a problem and a burden to society that the stigma associates them with already.
Thank you all so much for discussing some of the things that you're working on to address this issue. All of your answers suggest that there is so much happening in this space. There's a lot to be hopeful about. And in terms of, we at the Health Lab like to think about data analyses and evidence bases. So in terms of ensuring that evidence-based or best practices are implemented at scale, I'm wondering, are there examples of how access to data or timely research can help design, support, or improve solutions in this space? And I'll just ask anyone who wants to jump in to jump in.
Well, I can give one example. I mean, I think there's been quite a lot of research done about so-called high utilizers of 911 services, and really doing a good job of characterizing what are the primary complaints and needs that people that are super utilizing 911 have. And it's often a mix of mental health, substance use, homelessness, and often comorbid physical health conditions. And so on a really practical level, it gets at kind of what Joel was saying earlier. If we want to interrupt that cycling, we have to think about how do we pair housing with holistic healthcare services that address underlying mental health and substance use needs, complex trauma, physical health conditions. I think it then goes to Nika's bigger picture question, which is, and then what does that suggest about the status and level of investment that have been made in communities where you're seeing that happen, right? I think 911 data is kind of a reverse image sometimes, because you can think about 911 events, not all 911 events, but some, as things that could really be ameliorated through direct investment. So if I see a lot of behavioral health hospitalization coming from a particular community area, I'm going to think about the level of investment we've made in affordable housing, in outpatient healthcare in those communities, et cetera. So I think the research is critical to helping us understand what interventions to pair together. And it's about accountability. That, we have to hold ourselves accountable. We should not be doing things that don't add value, that don't help residents. And if we can't demonstrate that they do, then we need to do something different.
I'll add to that and say that, the utility of research is great. What I push us to do is to consider the great solutions that can occur if we equip community with the knowledge that we have from research and data, instead of continuing to equip systems with that knowledge. So investing in community by investing in their expertise is where I would say the research can and should go.
Yeah, I just add that, I often cringe when funders approach and they want us to respond to RFPs with evidence-based models. Where was the evidence gathered, and who were the subjects involved in the gathering of that evidence? I prefer evidence-informed, which gives us the flexibility to take not only the data with the hard research, but also some of the anecdotal things that we know from just knowing people and working with people, and add the two together to make sure that we don't that people don't fall through the cracks because of some rigid data set, even though we know that their data is not absolute, right? And so I think that's one of the things that we should think about, and I want our funding partners to think about as we move forward from the federal level down to including philanthropy. Evidence informed may be better in some instances than evidence based.
Thank you. Those are really critical points, and that we take data and analysis and evidence seriously, and I think those are all critical. So we've talked about the challenges, we've talked about some of the solutions, and I think now we'll open it up for Q&A. We've got a couple of questions coming in that I will read off to folks. The first is, I am a 1989 Harris School grad and am transitioning to ordination as a deacon in the Methodist Church. How do the panelists see the role of the church as part of the crisis response network?
I think huge, honestly. As a provider, like in the community, I work a lot with our religious groups and support, because your part of your flock may come to you, right? Because you're trusted, you're safe. There's a lot of stigma around addiction and mental health. So part of what you can do is help break down some of that stigma, help them get to services before they hit crisis, right? And I think that is one of the most important roles as a community leader that you can have, is to help connect individuals to services, use evidence-based, right? And destigmatize and normalize treatment and recovery for your individuals and community members.
I also think, when you're thinking, I did my MDiv and my MSW at U of C, and I think when we think about mental health, we often think about like clinical services. I actually think that's a very narrow conception of what real lived mental health looks like. I mean, to me, mental health means feeling connected to other people, feeling seen, being able to show up as you fully are, being able to be safe, having a sense of meaning and purpose in your life. And I think faith communities are critical and play that essential role for a lot of people. It's about community, it's about connection, it's about purpose, it's about being able to be your deepest self. And so I actually see faith communities as critical to having this more holistic sense of what does it mean to be well? What does that look like? And I think faith communities are often moral centers. They often push. There's a prophetic voice that comes from faith communities. And I think that's critical as well.
Yeah, I think faith communities are a critical and underappreciated part of the equation, at least in policy circles. And you talk about situating resources in the community. They're a great connector, obviously not the only one, but a critical one. And so next question, with regard to resources, funding the infrastructure for new and improved crisis response will cost money. How do states like Illinois fund such a system? That's a tough one.
Is the question, how does Illinois fund it?
I think, thinking about all of the funding that's needed to improve the infrastructure for crisis response in the ways that we're talking about tonight, where does that money come from?
Yeah, well, so of course, this is largely publicly funded, and Medicaid is a driver, of course, to funding this type of work. I think that we need to really take a look at how serious and how important this type of work is, particularly on the prevention side. In Illinois, our lawmakers have been doing a good job in recent years of trying to pay attention and move the needle with funding, but we really do need to make an investment in the rates. Especially with the increase in the minimum wage, there's some staff at our respective organizations that are not making much more than minimum wage, because as minimum wage has grown, funding for these services has not, and not at the same pace. And so we're asking people, we're telling people they're professionals. We're giving them titles like counselor and credentials like CADCs, but the funding through our contracts with the state of Illinois are very similar to minimum wage in our state. And I think that we have a workforce crisis that, even funding aside, we don't have enough social workers, counselors, et cetera, entering the workforce. So we really need to make an investment in our educational system around the importance of the work leading to healthcare and social changes in our society. So all that's going to take money as well. I don't know if I answered the question or added more to it, but I think funding is definitely a key to making this all work.
I also think loan repayment programs and training programs and employment opportunities, especially for peers, are really important, because they can be such a great resource for patients who are in crisis. And that's another area that I see we need to improve a lot.
I think there's a lot of money going into states for 988 implementation, and I think it has to be sustained, as Joel said, through really robust Medicaid rates. But I do think that funding will help build this system. And I think on the 911 side, the reality is cities already spend a lot of money on 911 and 911 dispatch. So it's really about, are there different ways to think about how you invest that money to get bigger impact? So for instance, one of the things we're starting this fall is embedding mental health professionals into the 911 call center. We know that's a best practice from other cities. There is a certain number of calls that you can resolve appropriately over the phone. You don't need to do any dispatch at all. So you then save money through the dispatches that you aren't needing to send. And what you think about, where can those monies be reinvested across the system? So I think it's a combination of Medicaid reform, city municipal budgets, and also thinking about federal dollars.
And then let me just say that we have to be careful, and Matt and I have talked about this before, that we're not stealing talent from one part of the system to push into the other part of the system, because the system is still hurt, right? And so if there's an infusion of new monies, let's say at the city, to do these enhancements that Matt just talked about, where is that talent will come from? Because we're already in a workforce deficit, as I indicated. So we can't build something that's going to create a fracture somewhere else in the pipeline. And we just have to always be aware of that. As new monies come in, does it pull away talent and then create an additional deficit or a greater deficit somewhere else down the line?
I wonder, this also brings to mind the nature of how we structure funding for lots of this. Sure, lots of it comes from city budgets, state budgets, but especially when we're talking about innovations, it strikes me that a lot of the funding happens from, in a philanthropic way, either from federal grants or private philanthropies. And those, and Joel, you alluded to this earlier, but lots of those come with certain strictures around the funding, things you can do and can't do, things are funded, unfunded. And I think even more fundamentally, those are funding streams that last for a certain amount of time, say a year or two, and then they dry up. And so is that, has that helped to create some of the fractures that we see, or is that sort of an unrelated issue?
Well, I think it's helped to create that, but it's also helped us identify, in some cases, what works and doesn't work. Now, what I will say about private philanthropy is, if we're in the middle of a grant cycle and we're recognizing that our intended goal or the methodology to meet that goal is not really working, and we identified barriers, oftentimes we're able to go back to that funding partner and say, hey, look, we recognize that going down the left path isn't working, but we see a pathway to the right. And if we talk about it in advance, then they're usually amenable, but it isn't sustainable, right? I mean, at the end of the day, after a couple of funding cycles, we have to figure out another way to pay for it. I think opportunities for blended and flexible funding, looking at value-based payment structures within the Medicaid market that allows us to be paid for the outcome and not necessarily the path to get to that outcome, are things that are really going to prove favorable in overall treatment response, crisis and non-crisis alone. So I think that there's opportunity even in funding that's not sustainable to at least help us discover that innovation and then make an argument for sustained funding elsewhere.
And what I'm hearing from the group, particularly from Joel, is the importance of flexible funding being invested in those community experts. And we talk about, how strapped the workforce is within the city of Chicago. To me, that's all the more reason for us to look towards the expertise of community and really think about how the flexible funding from the philanthropic community can help to move the needle in this work.
Thank you. Okay, I think we have time for one more question. So it is, the panel mentioned looking upstream. Can the panelists give some examples of upstream changes that go beyond service delivery to change the structures that perpetuate inequities in health and health-related factors, such as not only access to, but control over resources, wealth, and control over resources and wealth?
Yeah, I mean, I can give, there's been this discussion, related to the combination of drug overdoses, suicide, and alcohol-related injuries, and how they affect life expectancy in different groups, and starting to call those the diseases of despair. And one of the things people have found with that is that, you know, people are at increased risk for instance, for developing a substance use disorder and drug overdose if they're unemployed. We see suicide rates in states go down when the minimum wage goes up. When we think about workplace, when we think about the psychosocial nature of someone's work, is their work manageable? Is it fulfilling? The mental health impact that has for people. We're not used to thinking about levers like minimum wage or robust unemployment benefits as mental health interventions. They absolutely are. When we think about affordable housing and we think about having a robust supply of affordable housing in a community, that is absolutely connected to 911 utilization. In any study that I've looked at, when you're looking at super utilization of 911, homelessness is always at the center of that picture. And when people are sort of living paycheck to paycheck, when you have a housing market that's not affordable, you run the risk of that being a reality for more people. So that would be some examples.
Yeah, I think opportunities like this, we have to do a better job of educating the public more broadly around what our challenges are and to reduce stigma. Because even if we talk about building housing, we still have this NIMBY mentality where we like what you do, we don't want it in our neighborhood. Well, people have to live someplace. There has to be a neighborhood, and it shouldn't be congregate care where all people with substance use disorders live in this neighborhood, or all people who previously experienced homelessness move into this neighborhood. We're all citizens of Chicago and Illinois, and there needs to be a broader educational piece to help our citizenry understand that we're all neighbors. I think we talk about flexible funding, but I don't want it to seem like we're all dependent on taxpayer dollars. I think what's interesting is in this past April, for the first time, marijuana tax revenue surpassed alcohol tax revenue. And we know that those marijuana dollars are earmarked to reinvest into services. And we also know, I don't think anyone is under the misconception that illegal marijuana sales stopped. So the fact that legal marijuana sales and the tax revenue surpassed alcohol sales and will continue to surpass alcohol sales, there's a lot of dollars, more than we anticipated, coming into the system that can be reinvested. So there are opportunities to look at other funding sources beyond just increased tax revenue or Medicaid dollars to help us fund a revolution.
So yeah, I mean, there's lots of levers that can be pulled, potentially more dollars to do it with. You know, it's can be quite daunting to think about all of the changes that need to be made. You know, one way to think about it is, well, we just need to fix everything and then crisis response will be better. But I think maybe a more helpful way to think about it is that there are lots of routes in, and if we just sort of try new things, we'll hopefully have success. And so I think at this point we have to wrap up. So I want to say thank you again to our panelists, to Dean Baker, to Dr. Pollack, and of course, Health Lab's own Amy Spellman. I hope today's discussion challenged us all to expand our definition of what we conceptualize as crisis response. I'm really excited to see how we can continue to reimagine and improve crisis response in Chicago and beyond. Now I'd like to turn it back over to Amy.
Thanks, Jason. And of course, just to reiterate Jason's response, thank you, of course, to our panelists for your time and sharing your insights and guidance about the city's strategy to solve these incredibly complex and cross-system issues. I also want to thank everyone who joined tonight. Before we let you go, I'd like to plug 2 upcoming events. First, the final event in this series will take place in August. Our partners at the Education Lab will be discussing personalized education and the implications of their findings for American public schools in the context of a post-pandemic world. Registration details will be sent out in a few weeks. And finally, I'm also excited to announce that we will be launching the inaugural Transform 911 event that Harold mentioned earlier. It will be held on September 17th, and we are convening national experts and stakeholders as part of our Transform 911 work to discuss the state of 911 and transformation efforts. So again, that event will be September 17th, so please keep an eye out for a save the date for that and registration information to follow. And that's all I had. So thank you again for everybody who participated tonight.